After that wonderful session to kickstart the day on public policy, we now have another equally important session focused on healthcare. It's my pleasure to introduce my colleague Mark Allen, who's the Executive Director of the Max Institute of Healthcare Management. Just a couple of words about Mark before I invite him to take over the proceedings. Mark has joined us this year in January, and he moved from Boston to Mohali. Quite a switch, Mark, for you from Boston to here. Mark maintains a faculty appointment at the Boston University School of Management, and for 5 years was on the faculty of the Department of Family Medicine in the School of Medicine. He has had a long history of executive positions in the healthcare industry, as well as having provided consulting in an array of settings. He built and ran a health insurance scheme using government funds to purchase private care for the poor, was CEO of a series of non-profit agencies providing government-funded services, including primary care, and ran a purchase of service system for government that contracted for services from the private sector. Over to you, Mark. Thank you. Just a programming note before you start. Can I request all of you to please put your phones on silent or vibrator mode, and especially the WhatsApp tings as well. Thank you so much.
I'd like to welcome you all to our second program, Public and Private Together, the Road to Universal Healthcare. And welcome also to those of you who may have joined us who are in the industry one way or another, have a concern about it, who came here for the session. Very good to have you here. I just wanted to make 3 framing comments before we get going, which are my opinion only, but I would say 1, healthcare has been substantially neglected in India historically, demonstrated by health indicators that are similar to some of the poorer countries of Africa, demonstrated by a GDP spend of about 4% and a government spend of hardly more than 1%. My suspenders are being repaired. Okay. So first, that's the historical. Second, we are in a period of tremendous change, as demonstrated by government embarking on universal health assurance as a priority, and a growth rate in the industry that's 3 times the growth rate of India as a whole. Third, that change must involve the public and the private sector together, even from the public sector view. Over 70% of all care is delivered through the private sector. And if we're going to meet the needs of all Indians, we must bring those 2 parts together in cooperative ways to create value for people. Now, that's the context for the program we're doing. And we have today 4 excellent speakers. If you look at your old program, you'll see Love Verma was listed, Secretary of Health for India. Unfortunately, his boss yesterday afternoon told him there's now a meeting this morning that he must be at. So Anil Zawarab, a member of the panel, has kindly agreed to step up and ably take that role of lead-off speaker. We will have the speaker, we will have some commentary by each of the panelists, and then we'll have Q&A session. Let me ask first Anil Zawarab to come up. Anil Zawarab, you may see he's Secretary, Ministry of Coal. No, we've not made an error or mistake. He extraordinarily, while in the Department of Labor, started RSBY, the National Health Insurance Scheme, an extremely, maybe one of the most innovative actions in government in the last 20 years, certainly in healthcare. So he is an innovator from the government side who's had a huge impact. Second, we have Sarang Dio, who is a professor, assistant professor of operations management, Indian School of Business, and what I call a healthcare guy, meaning most of his research is within the health arena. He extraordinarily brings elite international level research and a concern with application in the real world, which is a trademark for ISB, that combination. Next, Milan Rao, who's Chief Operating Officer at GE Healthcare of India and South Asia. And I could testify, having been to the John Welch Center a number of times, they're innovative leaders in frugal innovation and actually in public-private partnership also, and he will talk about that. And then finally, Mandar Vaidya, McKinsey. He's a lead partner in India in healthcare, and joins us to give some general background about public-private partnership within healthcare. So I will hand it now over to Anil Swara for opening remarks. Thank you so much.
Good afternoon, everyone. The past 1 month has been a pretty good one. I have been promoted twice. First, I became co-secretary, and today, thanks to ISB, I've been promoted as the keynote speaker, so you'll have to bear with me. In cricket parlance, to be an extra, and then become captain of the team. Now, what is this man from coal doing here in this conference relating to health and public-private partnership? We did a small experiment in India way back in 2008, wherein we discovered that public facilities alone were not sufficient to carry out the humongous task of providing healthcare to the people of this country, primarily the poorest of the poor. And I will not like to put before you the data for coming to this conclusion, but I was convinced with insurance, and I must share with you the first meeting when this scheme was literally pushed down my throat. It was a meeting chaired by Mr. Chidambaram, who was heading a group of ministers, to follow up on a declaration made by the Prime Minister that there should be a health insurance scheme for the poor. Obviously, he looked towards the Secretary of Health and asked him that it's a health insurance scheme, so you work out a health insurance scheme, and the meeting is over, the decision taken. The Health Secretary said, no, sir, we are grappling with this new baby called NRHM, the National Rural Health Mission, and we won't have time for doing this. So the second obvious choice was Secretary Institutional Finance, looking after banking and insurance. The gentleman later on became the Comptroller and Auditor General of India. But at that point in time, he said, sir, we are trying to do a scheme called National Health Insurance Scheme, Universal Health Insurance Scheme, and it's going nowhere. So as it happens in a group meeting or a meeting like that, suddenly there was no solution available to the problem that was posed, that there should be somebody doing the health insurance scheme. So they looked around the room, and unfortunately, I was the junior most officer sitting in that room. That's how it happens in bureaucracy. Someone mentioned to the finance minister, sir, ye Anil kar lega. Now, who the hell is this Anil? So I stood up with folded hands, sir, I don't know anything about health or insurance. But Mr. Chidambaram is a smart man. He said, this scheme is for unorganized workers, and you are responsible for unorganized workers, and hence you should do that scheme. So I told him, sir, by that logic, all schemes of the government should come to me. But I was over. He said, no, it's for unorganized workers, you do it. And believe me, I still don't know much about health insurance, I know a bit. But at that point in time, I didn't know anything. And the decision was taken. So I come back home, and whenever you are in trouble, at least when I am in trouble, I go back to my wife. I asked her, do you know anything about health insurance? The answer was very obvious. So what do? I keep awake for 6, 7, 8 nights. And probably on the 9th night, I penned down 300 odd questions, first of which was, what is health insurance? So that's how the journey began of this scheme, which I am now proud of. The Rashtriya Swasthya Bima Yojana, the health insurance scheme. Perhaps the only health insurance scheme which is paperless. Perhaps the biggest health insurance scheme in the world. And perhaps the only public-private partnership for a social sector scheme. Now, this scheme fortunately came to be recognized world over, much before it came to be recognized in India. And as it happens, when yoga becomes yoga, it gets to be recognized in the country of origin. So when it got recognized world over, World Bank took notice of it. I was called over to Washington, not once, many times, because World Bank also wants to take pride in something good that is happening in the world sometimes. So they call you over and they ask you to make presentations. So I did make presentations. They were very impressed that this is a brilliant scheme. This should be replicated in other countries of the world. So I was asked to do it in 15 countries, and then finally thought, grab this man. They gave me a stupendous offer to join the bank to do this scheme elsewhere in the world. But fortunately, I didn't do that because I'm enjoying my existence in coal mines these days. So I stayed back and I'm doing this work here. But how is this a public-private partnership? Now, so far in the first 50 years of independence, India had gone in for what is called the supply management of healthcare, not the demand side management of healthcare. And this, we were challenging that supply side management of healthcare, and we said, how about putting this money in the hands of the user and allowing him to go where he wants to go, public or private? That was the challenge. Now, the scheme happened in India because before people realized that it would happen, it happened. Because had they realized it earlier, they would not allow it to make it happen. Because, supply side management is very strong. Now they have discovered this scheme and they want to stop it tooth and nail, that only government hospitals can provide healthcare in this country. We were of the view that we have to work together because the task is so stupendous that only one cannot do it. So when we started this journey, what we did was, and this was very important, we looked at the consumer very closely, and that's not what the government normally does. We looked at him very closely before formulating the scheme. We thought that this guy was by definition poor, so the insurance scheme had to be cashless. He couldn't pay and then claim that amount from the insurance company. It's virtually impossible. Most of these guys were illiterate, so we couldn't have a paper filled, because those insurance documents, God help us, going through those documents, even I can't read those fine printed documents. So the scheme had to be paperless. Now even today there's no other paperless health insurance scheme in the world except the RSPY. That was a very difficult task to be done. And finally, and most importantly, in India there's a lot of migration that happens from one place to the other. So you had to provide them portable benefits. Now no scheme in this country provides portable benefits. A PDS, public distribution system, you got to be in that village in your district to get the benefit. In NREGA, you can't work outside your district. But here is a guy who travels from, say, Bihar to Punjab. We can't tell him, don't get sick there, don't get into an accident because you are not covered. So they had to be portable. Now, that is where public-private partnership came in. Now what we did was that the drive was coming from the government, and I'm a great believer that volumes and drive has to come from the government, efficiency has to come from the private sector. For me, the difficulty was to convince my colleagues that this sort of a partnership is possible. Because, as it often happens, government has serious doubts about the capacities or the intentions of the private sector, and the private sector has grave doubts about the capacity of the government machinery. But we could break that nexus, and we could get together and tell that let us leverage each other's strength and let's get moving. How did it happen? So the government provided the fund. There was a set of public and private insurers who came in. There was a set of private people who did the smart cards in the field. And mind you, this smart card is actually issued, printed, handed over in the village. And of the smart cards numbering about 37 million now, not a single smart card has been issued to a wrong person. There's a foolproof mechanism. I will not go into it. So the security part and the foolproof part was provided by the government. The actual delivery was done by the private sector. It's an amazing model of public-private partnership, which demonstrated on the field that the two could work together and deliver it on the ground. And probably that was the reason why the UN and ILO picked up this scheme as one of the topmost social security schemes in the world. Almost everyone's talking about this scheme except within the country, because it was not sexy enough to be printed in first or third pages of the Times of India, Hindustan Times. It was for the poorest of the poor, and poorest of the poor we only discuss sometimes. Otherwise it doesn't get printed. So it never got noticed. And ironically, when it did get noticed after 3.5 years, they discovered one Mr. Anil Swarup. They plugged him out and they say, you do some other job. So I was earlier serving the poorest of the poor. Immediately they were asked, thereafter I was asked to serve the richest of the rich. I was made head of a group to monitor projects above 1,000 crore, both public and private. My entire budget for RSBY was 1,000 crore. Here I was handling each project was 1,000 crore. And in the 15 months that I spent there before I got into this business of doing coal, we did 6.5 lakh crores worth of project in the 15 months there. So when I compare this service to the rich and the service to the poor, I must confess to you, I was thoroughly enjoying the business that I was doing for the poor. I remember very clearly, in one of my visits to the US, the Obama administration got interested in what we are doing because the health insurance was failing there. Time permitting, I'll explain to you how is this so very different from what is happening in the US, because this insurance system is totally different from the US. So when I was making these presentations at the Brookings, where the advisors of the presidential administration were sitting there were some gentlemen from foundations, Ford Foundation and other foundations. So one of those guys, after the presentation came to me, I was having a cup of tea. They asked me, Mr. Swarup, you are a bureaucrat, but you seem to be very passionate about what you're doing. What is driving you? You're just getting your salary. Very interesting question. So I didn't have an immediate answer. I asked him a counter question. I asked him, you give millions of dollars to poor countries all over the world, what do you get out of it? So he said, well, that's our job and we derive a lot of satisfaction and this and that. So I said, you've given my answer. I don't spend a single penny from my pocket. Yet all the good wishes of all those very poor people come back to me somehow anyhow. What could be a better motivation than that? Then I gave him an illustration, which he understood. I mean, initially it was difficult. I told him that I am very fond of visiting hospitals. In one of the hospitals that I visited, and these are not those Apollos and Maxes. Unfortunately, fortunately, these rich hospitals never became a part of RSBY because they didn't want dirty people to come into their hospitals. But they were B and C category hospitals. And in one of those visits, there were many such experiences, but I'm narrating one to you, which I told that guy. That there was this old lady, she was around 100 years, because RSBY does not have a ceiling of age. Anyone can, any poor person could be registered. And she was beckoning me. You know, someone told her that I had something to do with RSBY. I say, I hope most of you understand Hindi because the language will get lost if I speak in English in that. He said, Beta, idhar aao. So I went to her. Beta, मैं बहुत तकलीफ में हूँ. I am in a lot of pain. I said, माता जी आप ठीक हो जाएंगी, ये लोग आपका ख्याल तो कर रहे हैं. I hope these people are taking care of you. हाँ बेटा ये तो बहुत ख्याल कर रहे हैं. They are taking good care of me. और बहुत ही ज़्यादा ख्याल कर रहे हैं, सुबह शाम मेरा ख्याल करते हैं. बट मेरी बेटा अब उम्र इतनी हो गई है, मुझे ऊपर वाले के पास जाना है. सो आई ट्राई टू टेल हर, नहीं नहीं माता जी, यू विल बी ओके, ठीक हो जाएंगी आप, जब इतना ख्याल कर रहे हैं. नहीं नहीं बेटा, मैं ऊपर वाले के पास जाऊँगी. ऊपर वाले के पास जाके एक बात जरूर कहूँगी, तुम्हारी स्कीम बहुत अच्छी है. नाउ व्हाट एल्स डू यू वांट in life? That's it. That is it. That is the driving force. Now, why I mention this here in a public-private partnership? There, we were traveling together. The people from the government and people from the private. One, if you talk to anybody in RSBY team, fortunately, I was using this social media, which is now fashionable now. In doing that scheme, I was in touch with about 1,200 people in the field on the Facebook who could reach out to me anytime, give their comments to me. And these were all private people. Talking to the man who's doing this scheme sitting in Delhi, they could convey to us. Why I'm mentioning again this is that we worked in tandem. No, whatever you may discuss here, unless we actually get into a partnership, not in the written sense, where we write in a manner that later on if we got to sue each other, we'll sue each other. It's like a marriage, you know, preparing for divorce before you get married. So it's public-private partnership is, they should have, the private sector should have a business interest. No, when I went to the planning commission in the beginning, and I told them we don't have targets in the real sense of the term. So they said, then what are you doing? I said, we have different sets of targets because usual targets won't work. Because this is perhaps the first ever business model, as I said, for a social sector scheme. Now, the insurance companies were given premium as a multiple of the number of smart cards that money as a multiple of smart cards that they issued. So they were incentivized to issue as many smart cards they could. They could issue to a wrong person because we had a government-based security system. I am not going into the details of it. The hospitals obviously will attract as many patients as possible. So everyone had a business interest in making this scheme happen, and perhaps that was the reason why that scheme happened. And I think the primary reason was that each stakeholder found value in what was being offered. That is how the scheme happened. I am so glad that I was at some point in time associated with it. I must confess to you that I found it extremely difficult to detach myself from that scheme. I still think of that scheme, I still live that scheme, I still reinforce that scheme. It's a different matter that now it is being tossed between two ministries. I hope it survives that tossing. Thank you very much.
Thank you so very much. In that example of framing funding source, of an example of what I would say is innovation by action rather than just contemplation or planning, and that glimpse of the life of an IAS officer and their family interactions at crucial times. Now I'd like to hand it to Mandar to comment a little bit on the other vehicles of BPP that exist and where India stands at this moment in time, briefly.
So firstly, I think Mark, you've put me in a tough spot following Anil and that fabulous fabulous speech full of anecdotes of what is clearly, to my mind, the shining light of PPPs in healthcare in India, without any doubt at all. I think to your question of speaking, trying to speak for a few minutes about the status of PPP in India and the state we find it in. I've been seeing the dialogue sort of from the side, if you will, as the government and various stakeholders in healthcare have been interacting on this topic for the last 6 or 7 years. And healthcare obviously has different elements to it. There's the payers, there's diagnostics providers, diagnostic equipment manufacturers, device manufacturers, there's pharmaceuticals, there's providers, hospitals, nursing homes, doctors, and so on and so forth. And in some ways, I think the dialogue around PPP in healthcare in India, I've seen it move slightly or substantially over the last 6 to 7 years from where it began, when a lot of the questions were about the what and the how. So a lot of the questions 7 or 8 years back were about, what should a PPP look like? What should the government be doing? What should the private sector be doing? How will we, put this together? I remember several discussions around what should a good PPP contract look like, looking for examples elsewhere, outside healthcare in India, outside India in healthcare, so on and so forth. And there was a lot of debate and discussion around the what and the how. And the why was taken as a given. That, of course we need PPP. It was almost a sort of a underlying bedrock. Interestingly, the discussion gradually moved to one where people started saying, look, we actually have enough frameworks for what and how now. We seem to know what needs to be done by the government and the private sector. As Anil mentioned, the government bringing in the volumes and the drive and the funding in many cases, the private sector bringing in efficiencies, contact and knowledge about the consumer and the ability to deliver things. And the how, there were models out and about, various forms of contracts, and certainly in India, PPP had begun to thrive, outside of healthcare in some of the other sectors. And for long, the conversation then shifted towards why is it not working then, and are we missing something? And the word trust started getting spoken about, I think about 2 or 3 years ago openly. Again, something Anil mentioned, where both sides are not fully comfortable with the other. And on that, I wanted to use this occasion to go a little bit deeper, because I would say that with a couple of exceptions in terms of sectors, certainly the payers is one substantial exception with RSBY. I would say diagnostics and particularly partnerships between diagnostics manufacturers and consortia with government is probably another area of exception. But with these couple of exceptions, I think the rest of the healthcare domain has moved a lot slower than others would have wanted it to move forward. And I think as we have tried to think about why this is and gone a couple of steps deeper, we have actually found 2 reasons for it. Let me talk about these reasons, and then I'll come back to Mark's suggestion to talk about the state of play. I think the first reason is the dramatically fragmented nature of the healthcare industry. And I don't think it is a coincidence that payers and device manufacturers or equipment manufacturers, which are probably the 2 parts of healthcare which are least fragmented as compared to, let's say, healthcare providers, where literally if you start counting each individual nursing home as a provider, it's probably one of the most fragmented industries there is. Or if you look at pharmaceuticals, where there's more than 1,000 pharmaceutical companies in India. What the fragmented nature has done is, I have seen in dialogues often the government facing a very real and substantial issue, which is who is the private sector? Who represents the private sector interest? Because if you talk to associations, often it is the top 5 or 10% of any stakeholder group of healthcare which is represented there. Whereas from a government point of view, it is often the remaining 90% which is offering care to sort of the masses. And therefore, how do you begin to understand what really the real private sector, if you will, wants, the unorganized private sector, and how do you begin to solve for that? We have found that is a little bit of a hurdle. Being able to articulate that has proven to be a little bit of a problem. And the second is priorities of the private sector. And again, given the fragmented nature of different parts of the healthcare stakeholder spectrum, of course, PPPs are at different levels of priority depending where you look at. Again, I would argue that with payers and with equipment manufacturers and device manufacturers are probably the 2 areas where without there being a substantial partnership with the government, meaningful growth and step forward was very difficult in India. And so for the private sector, it bubbled up in terms of priorities to a very high level. And so, the private sector had to sort of come and sit face to face and attempt to solve a problem. I see that changing, but I would say that, in the private sector, people have hitherto managed to somehow make it through without being extremely dependent on the government. And the effort has always been to reduce dependency on the government to the extent possible. And by government, I mean, various schemes of the government, as well as having to partner with the government on the provision of care itself, as opposed to just the payment of care. When I look at where things stand today, I would say that on both things, I see things shifting substantially. Firstly, in terms of the fragmented nature, whereas there is consolidation, obviously the consolidation still is not solving for all of the private sector. The bulk of the private sector still remains fragmented. But at least the priorities of the private sector are beginning to get more aligned as the sector gets more organized and beginning to get more uniform, such that it's becoming easier for both sides to talk sort of at the same level and the same wavelength. And secondly, in the private sector is facing what I like to call the demand-supply paradox of India, which is that on the whole, whereas India is quite substantially supply constrained in the sense that we definitely need more infrastructure and resources, whether it's beds, doctors, nurses, you name it. However, in reality, the beds, doctors, nurses that do exist are not utilized fully or effectively. So at the same time, there exists a supply constraint and yet a situation that not all beds are overflowing and not all hospitals are overflowing. And so private sector is beginning to realize that to ensure that this demand-supply match happens, that they do actually fully utilize the infrastructure and the resources that are available to them, there has to be a dialogue with the government, and this is rising substantially in priority. And so if today where I'm standing, I am actually very, very optimistic, more optimistic than I have been in the last 2 to 3 years. And I think if you look at statistics also, you see that across the board, not just at the center, but various state governments, I think the disparate number of schemes in private-public partnership which are emerging has actually increased quite substantially. The big sort of dramatic examples of RSBY, of course, but even at the smaller level when it comes to setting up diagnostic centers and hospitals and so on. So that's what I would say.
Thank you, Mandar, in summarizing a 2-day conference into 7 minutes and ending on an optimistic note on top of that. We'll come back to some of those issues, and thank you for those framing comments. I'd now like to hand it over to Milan to talk about one of those examples of areas in which I think private innovation has added a great deal of value in the context of PPP.
Sure. Thanks so much, Mark. And it's interesting that you talked, Mandar, about where PPP has really been successful. And I think clearly insurance is one of the biggest examples that we have. But I think while we don't have this huge, big example of insurance, I think we have tremendous number of small examples of what has been done in PPP across states in the diagnostic space. So just like to talk a little bit about that. But I think while we talked about the requirement of PPP, I think a couple of things are very important when you look at the diagnostic space. And I think the first one is technology, because the process of procurement, the requirements at hospitals, they're changing over a period of time. And technology obsolescence, getting the latest technology and technology obsolescence is a huge part of what needs to be addressed. And I think that's one of the things that that has prompted the government, in many state governments, in fact, to actually look at PPP models within this space. And I think there we've been hugely successful. The second part is that it does cost a lot of money. There is a lot of capital investment. If you actually look at setting up of an MR, for example, each MR would be $1 million, each CT would be perhaps $500,000. How do you make sure that if you're going to granular level at districts, at individual hospitals which are there in each of those districts at the panchayat level, then how do you account for so much of capital expenditure? And I think to that extent, I look at public-private partnership not just in terms of what has been talked about, but also in terms of it is a mechanism whereby the burden actually gets shared between public and private, and for different reasons, sure, but it gets shared in a way that is PPPs which actually happened. So Gujarat, the concept was that at district level hospitals, they wanted high level of diagnostic screening. So equipment such as MRIs, CTs, DEXAs, X-rays and so on were required at district hospitals. And there was a partnership which got created wherein the private operator was expected to run the diagnostic center. The hospital gave its premises for running the diagnostic center. Now, why did the private guys who bid for it, why were they really interested? They were really interested for two reasons. The first one is that you actually get a steady patient flow, right? Because the predictability of a model actually becomes very important when you go in for a PPP. If the model is unpredictable, the likelihood of the model succeeding for a private entrepreneur is going to be very less. The second one was that the terms and conditions which were laid down within the requirements were very, very clear. The terms and conditions were that the healthcare and the diagnostics had to be provided at certain levels, and those levels were much lower than what you would get in a normal PPP scenario, in a normal private scenario. And the people who are below the poverty line were expected to be treated for free. And the government had a mechanism of reimbursing that, as Mr. Swaroop talked about. So clearly, when you have a model in which there is predictability and there is transparency, that model really starts working. And that's really an example of what happened there. And then indeed, this model actually got extended to states such as MP. Andhra Pradesh, in fact, has a very, very successful large PPP. Karnataka, and I'm just talking about the states where Wipro-G has participated in these kind of PPPs, and I think it's been tremendously successful. By the way, the technology which is getting deployed at these places is high-end. So we went in for 1.5 Tesla MRs 6 years ago when 1.5T was, in fact, the gold standard. We didn't go in for single dual slice CTs at that point of time. 5 or 6 years ago, went in for 16 slice CTs. And the upgradability of each of these was also maintained in each of the PPPs. So therefore, if you had a situation where there were newer platforms or there were upgrades, then those were offered for free. The maintenance was outsourced to private, and therefore, as you talked about, the efficiency was very, very high. And the last point I'd like to make on why this is successful is that if I look at any industry within India, right, the concept of any industry being successful in India is the sheer scale that India offers. Sometimes we tend to get extremely concerned about the cost and the rates and the prices, therefore. But there is an equation and there is a sweet spot, and this is proven industry by industry, that if there is significant amount of scale, then even at a much lower price point, there is tremendous success. And I think, I can certainly talk about telecom, where I was last there, and I see a couple of members here. The cost of delivery and the pricing in telecom is so low, and yet the industry, due to the scale, has been able to succeed to the extent that they have. And I think exactly the same thing goes for healthcare. There's a requirement for people at such a high level that even at lower prices, those kind of PPP models have worked really well. The second aspect of it is clearly, universal healthcare is about two major things. There is accessibility and there's affordability. And how do we make sure that both accessibility and affordability are provided in order for universal healthcare to be really successful? I think I'll talk about accessibility because that's where, in fact, you alluded to the concept of innovation. So when we were looking at an industry, babies are being born. Unfortunately, 1 million babies die within 1 day of being born. And that's unfortunately the reality and the biggest issues every year. Now, well, and that number, by the way, increases substantially. It goes to 3 times if you actually take a first month or first quarter period. Now, if you are to look at the major causes behind why this happens, the major cause is that they either do not have the nutrition, or they contract jaundice because of exposure and temperature issues. And therefore, we sat down and said, okay, how do we address this issue of extremely high infant mortality? And we went back to the drawing board and we said, well, one way is for us to take our incubators, which are used around the world, and try and strip them down and make sure that the cost reduces for that. But how much do you reduce the cost? You can reduce the cost by 20%, 30%, 40%. So what is the competitive element here? What is currently being used for warming babies? And the answer is, the most common way is a 200-watt bulb. Now, a 200-watt bulb versus an extremely high-end incubator are worlds apart. So therefore, we started with the concept of we cannot do the kind of innovation which has typically been done, which is try and make sure that there is stripping down of costs and creating something which is of reasonably high quality. But we said we got to start dirt up. You got to start from the concept that here's a light bulb, and you got to create something that is robust, that is scalable, that can be used in environments where there isn't power, that can be used by people who do not know how to use it. And therefore, we came up with the concept of a lullaby warmer. And our lullaby warmer, as done up with frugal innovation, actually costs more than 90%, is cheaper than the incubators that we sell the world over. And similarly, we extrapolated this into things like ECG machines. So for instance, we created a Mac-I ECG machine where you could actually run an ECG for less than 10 rupees, for a single channel ECG. Now that's something which is dramatic. And therefore, for universal healthcare to succeed, it requires innovation of the nature which is right for a market like India. Because even if we actually created something which is 60% lower in cost, it would still not work towards our goal for universal healthcare. And therefore, all of us as industry actually need to come together and see what is the mechanism whereby you can actually get this kind of innovation. And the third part, Mark, is accessibility. And I think on accessibility, the role of IT is huge. Clearly, if you actually look at the skill gap between technicians, as an example, who are going to work our machines, there is a skill gap of nearly 800,000 technicians in India as we see currently, and that's likely to grow by double in the next 5 to 7 years. Now, if you don't have the technicians, and where is this required? This is required in Tier 3, it's required in semi-urban areas, it's required in rural areas. One option, of course, is to look at training technicians, which we'd look at. But the other option is to make sure that technology delivers to the location rather than the people traveling to where the technology is. And I think that's something that we all need to look at. How do we make sure that the usage of IT, whether it's telemedicine or creation of eICUs, that's a concept which perhaps we wouldn't have looked at maybe 5 years ago, but there is the concept where we've helped corporate hospitals create ICUs in Tier 2 and Tier 3 locations in smaller hospitals, which is actually monitored, including all the vital signs at the hub location. So I think we need to look at disruptive ideas for addressing the accessibility and affordability issues. And clearly, as has been seen in insurance or indeed in diagnostic imaging, I think there are huge examples and huge opportunities for taking universal healthcare to the next level.
Thank you very much for some compelling examples. And I think two themes in this. One is understanding how a business operates and the power of predictability and scale in creating value that allows the enterprise to flourish and the care to be provided efficiently. And second, the idea of disruptive innovation, where we look at things from an entirely different lens based on what India needs, and yet create business models that, again, are successful on both parties. Thank you very much. Now, finally, Sarang Dio, from the academic side, the neutral party, the researcher, how do you look at these issues and what jumps out at you?
As a token academic on the panel, I guess I have the license to be skeptical, so I'm going to strike that note. Optimism is good. I think we need to be driven by optimism. But at the same time, if you say, do we have a blueprint today of a successful PPP? I guess the answer is maybe, depending on the context, depending on the kind of service that you're trying to provide. And I mean, I live and die with for objective evidence and with objective evidence. And I have to say that there isn't a data set, there isn't a body of knowledge that says, here are the things that you need to do to make your PPP successful, or here are the common pitfalls. I mean, sure, people are writing about it, but to say that evidence on success of PPPs is mixed would be an understatement for the day. Right? And so one has to parse through this, and as Mark alluded, I think academic institutions, ISB and others probably are the natural neutral parties that can help and build that evidence. A simple way to start building that evidence would be to say, okay, let's pick up some successful PPPs and some not so successful PPPs, and let's sort of write down the key success factors and the key drivers for failure in each of these. This is what I would call as a case study method of research. It's a good starting point. It's clearly not the end point. You need to move beyond that and say, can we get objective data on the structure of arrangements? Those are these incentive mechanisms that other panelists have been alluding to. Could we get a data set of what these incentive mechanisms were? What services were covered in these PPPs? Were they for tertiary services or a primary care service? Clearly a PPP for doing tertiary procedures such as CABG or open heart surgeries would be very different than a PPP for delivering primary eye care in Northeast India. Both exist, and so the question is, could there be a data set or a bunch of data sets that could have these elements of what these schemes contain and what the performance of those schemes is? The big question then is, how do you measure the performance? Is it based purely on how many people did you touch at any point in time, or what were the outcomes of people? When you talk about outcomes, is it 1 week outcome, 3 months outcome, 1 year outcome? Again, depending on the nature of the disease, these would vary. But this is required if you want to come up with quote unquote a blueprint of how to make this successful in a replicable way. We talked about predictability. You also need predictability in PPP models. And coming from an operations or process background, I place a lot of premium on replicability so that it doesn't get left to a few smart people coming together on the table and making it successful. So that's one aspect, I think one place where academics can play a role, just to construct this body of knowledge, a body of evidence. The second, I think, is more in execution, where you have a certain PPP working. Could the academics again come to the table as neutral parties and say, let's evaluate this particular PPP. Let's decide on metrics of performance. Let's do before and after. Let's do a difference in difference and say, did this PPP achieve more than what private could have achieved by itself, public could have achieved by itself? Because in the end, you want the sum of parts to be more than the individual parts. And there are well accepted methodologies of how to do this. The question is, are we bringing those academics with those trainings on the table and saying, this is open for evaluation, this PPP is open for evaluation, because by evaluating this PPP, not do we learn about only this PPP, but these kinds of PPPs going forward. So that's the second part, I think. So one is in the design of PPPs through some retrospective analysis of a universe of PPPs. And second is execution of PPPs in real time, collecting data and generating knowledge and insights out of those. Clearly, none of this is going to be possible if it's left only to academics. So what I'm, I guess, appealing to here is the need for both public and private parties to come together and form a third partnership with academics, with the understanding that both public and private have the responsibility to actually deliver on the PPP, and they don't have time to sort of look at all these data being generated and analyze it in real time. This is best left to academics. And I'll give you one example of a PPP and something that I've been engaged with for about more than a year or so. This is a large urban TB control pilot that is being run in 2 cities in India, one in Mumbai, one in Patna, funded by the Gates Foundation in conjunction with the state and the city government. So in a sense, it's a real sort of public-private partnership. The goal of the public-private partnership here is to engage private providers to do early diagnosis of TB and to provide good quality treatment in the private sector. So this is one scenario where the public sector is actually a very good quality system as compared to a lot of private care that is provided. Yet most of patients who are suspected of having TB first go to private sector because they don't know they have TB, they're just coughing. And so you think, where would you go if you were just coughing? And I want to get back to this point about trust that was raised by Mandar earlier. At least based on my understanding, my time that I spent on the field, the mistrust is not sort of a unknown entity. It's not a blob. The mistrust arises in a lot of cases because the technical understanding of the problem is very different. So in the case of TB, the gold standard of diagnosing TB in the public sector is a sputum microscopy test, meaning you cuff out sputum, put it on a slide, look at it under the microscope. Whereas in the private sector, the gold standard, if you can call it, is chest X-ray. Now the mistrust to a large extent arises because they don't seem to agree on how to even diagnose TB. But then when you look deeper, you say that the reason for this, the difference is because the kind of patients who come to a public sector for TB diagnosis are very different as compared to the kind of patients who would come to a private doctor. When someone goes to a private doctor, that person is only coughing, which could be because of TB, but because of 10 other conditions. So the private doctor then has to look at a test that might give you a differential diagnosis on all of those 10 conditions. Whereas when someone goes to a dot center for a test, more or less all other options have been exhausted, and you have to rule out TB as a primary condition. So now all of these insights are impossible to obtain unless you spend enough time looking at data, looking at how things function. And I think this is one role that academic community can play in conjunction, as I've said before, with public entities and private entities. And hopefully, as this body of knowledge gets built, the failure rate of PPPs might come down over time, and success rate might increase. So I started on a skeptic note and probably ended at an optimistic.
Thank you, Sarang. And thank you for doing it in that order. You raised my spirits. Now I'm going to open it to the audience for questions. Having been to some sessions recently, I'm going to say these need to be questions, not statements of position disguised as questions. All right? Thank you. Anjan?
Good morning, everyone. I'm Anjan Bose, Secretary General of NATHIL, or Healthcare Federation of India, formerly CEO of Philips Technology. I have one question. The topic is driving India's growth momentum. So I picked up the skill part, Mandar's very appropriate fragmentation part, and Mr. Anil Swarup, of course, we all, you are a legend, and what you have done is very well appreciated. Technology part, I align very well. I necessarily didn't find a direct linkage with the topic, driving India's growth momentum, so some enlightenment, please, on that. That's a question.
Well, I could intervene and say our subtopic is universal healthcare, but if anyone wants to take a shot at that. We are growing at 15% CAGR in healthcare, so that's not a bad start. But
at the turn of the century, if my memory serves me right, there were only about 3 to 4% people in this country who were covered by health insurance. Today, the number is 26%. And it's growing. Now, the point that was being made by the panelist, I think, needs to be considered. That, okay, it has grown this way. What now? And that is where I think he put the word adding academics, because it makes a very bad acronym, PAP, Public Academics and Private Partnership. But nonetheless, we should have this PAP partnership to get this moving, to understand what has happened in the past decade. A lot has happened. And when we talk of universal healthcare, then the lessons not from the first 50 years, but the last 10 years are tremendous. There are projects that have done so well on scale. You know, in India, we are very fond of pilots, you know, but pilots don't fly actually, literally, and otherwise. The key is whether they have been scaled, whether they are replicable models, whether they've been scaled. And what makes me proud of RSBY is the scale part of it more than anything. There are problems, huge problems with the scheme. So what we have to see whether that could be scaled further. So I think the undercurrent of the discussion here was to take it there. Of course, no one specifically alluded to the topic there.
Yes,
Yeah.
sir. Oh, wait, you were there first. Okay, please.
Yeah, I'm Khaliqur Rahman from Young Foundation. In fact, as Mr. Milan said, Andhra Pradesh, in fact, is a very successful PPP model. And it was the government of Andhra Pradesh who had introduced the Arogya Shri scheme, which in fact has caught up very well, and which I think the other states are also trying to replicate that. And having said that, because we are very majorly lacking in the emergency services, and especially in case of the road accidents, most of the deaths occurring because of the non-availability of the medical help. So we need to focus more on the ambulance services, that too, the fully equipped ambulance services. So my question to Mr. Anil Swarup, that what is that the government of India especially, I know that the state governments and the government of India is making their attempts, but still, I think there is something, the connectivity lacking between the private sector and the government sector. Thank you.
In a way today, I'm like an academician, I can get away with anything. I'm not in the health sector, so I can say, okay, you ask the health secretary about that question. But having said that, I think you made a very pertinent point. And as I saw, I'm talking about a couple of years ago because I'm not in touch, a number of states government had picked up what they call the 108 emergency service, and it's doing very well in a number of states. I know for sure in Uttarakhand, they take pride in doing it. In Andhra Pradesh is doing very well. So a number of states are doing it. To my mind, the role of central government has more to be a facilitator and to a certain extent a regulator. The action has to happen in the states. I don't think central government should directly intervene in doing things there. It should be left to the states, and some states are doing well. I think what center should do is to roadshow the good work that is being done in some parts of the country so that it gets replicated elsewhere in the country.
Yes, sir.
I'm Professor V.K. Singh, Health Innovation Research at Ivy School, Business, Canada. It's a road to universal health. We have model of Cuba, which has got the best today in 2014. You have got China, who has got achieved 95%. Neighboring countries doing much better. Our growth have been from Mudaliar Committee 1950.
Wait,
to,
sir.
Yeah.
Question.
Okay. To MDG.
Remember, I
to-
warned you I would intervene.
Yeah. So we have failed somehow to reach where we should have, including MDGs, etc. You think we should continue with the same kind of a system what we are developing, or we need a hybrid system which is not in a US or other way? I wish Shri Anil Swarup would have come along with his RSBI to Ministry of Health, not only send RSBI to us. Thank you.
Anyone want to take that on?
Well, I can certainly take a shot at it. Well, to my mind, I think the models, whether it is a completely private model, there are very few countries, in fact, around the world which have a private model. In fact, one would argue that India is probably one of the most private models that there is. And on the other side, there are completely government-oriented models. There is the NHS kind of model, which is in multiple countries, notably UK, but in several other countries as well. I think that there is a question that I have back at what is a successful model. Is the fact that there is coverage a successful model, or is the fact that the patient treatment, the time of treatment, the ease with which the patients get the treatment what are the success parameters? So there are models where it works very well, there is coverage, but you have to wait for 3.5 months to get an MRI done. Now, is that successful despite the fact that 100% of the people can get it done? Or your disease has progressed so much that 3.5 months later when you actually get it done, you probably catch it at a very late stage. So I would argue that there is a rationale for a hybrid model. I think we need to take the positives from both sides. And if you really see, PPP to my mind is an attempt towards a hybrid model. And I think there will be various models, but I think this would certainly be one of them.
Yeah. Yes, sir.
Somewhat difficult to abide by your admonition to make it a pure question, especially if you fundamentally disagree with a couple of points. So I'll put 2 questions. It becomes difficult for you to answer. First one to you, Professor Allen yourself. How is it that 26% growth in health expenditure is anyway a sign of success or a positive move? Let me just put that question. The other question is with Mandar, with whom I fundamentally disagree. And to pose it as a question, what evidence, we are in the age of evidence-based policy in health, especially in health, what evidence do you have, ex post or ex ante analysis, to show that consolidation, which is the thrust of your remark, is in any way going to be a positive outcome or a positive direction for the Indian healthcare system? Because it's absolutely, I would say, the experience in UK, US, even in China, would say that that's the wrong way to go for a country such as India.
Thank you for the pointed questions. He's actually my uncle. I asked him to do that. No. First, yeah, he looks like me. First of all, it's 15%, not 26%, as far as I know. And that comment was somewhat tongue-in-cheek. Though I would say when spend is as low as it is in India, to expect that we're not going to have substantial growth or to see that as a problem. In the US, they're at the other end of the spectrum. We are way underspending in India. But growth and spend in itself is not a goal. It's useful use of resources. So the other question, Mandar, I think was...
No, I'll take the one on fragmentation.
Did I duck all right on that?
Sorry?
I ducked all right? Good luck to you on yours.
No, I think the words fragmentation and consolidation hide an extremely large spectrum. And when you talk of countries like the US and UK, they are so dramatically away from us in terms of consolidation that when I speak of consolidation, I don't foresee India reaching that level of consolidation in my lifetime at least, in the next 2 to 3 decades. The reason why moving more from the extreme fragmentation slightly towards center is useful, I feel, is for the following simple reasons. Regulating a sector such as this, regulating the quality of service that is provided in a sector such as this, trying to ensure that demand meets supply, which I spoke of, which is that the existing supply is utilized effectively and efficiently, becomes that many times more difficult if the sector as a whole is not consolidated, which means right siting of care is impossible. If there are 3 nursing homes on a street and 1 is full and 2 are empty, the fact is that a patient would rather, and this happens and we see it all the time, a patient would rather wait in line for a week or wait for a week for surgery because it's supposed to be quote unquote a good nursing home rather than go to the 2 neighboring ones which may not be rumored as good. My simple point is the consolidation which is happening today is going to take India from being utterly fragmented to being somewhere where at least the top 10, 15, 20% are somewhat professionalized and corporatized in terms of provision. So I am actually quite convinced that that is moving us towards the right direction. I think for us to reach the Western world's level of consolidation, I actually don't foresee that happening no matter what forces are at play. Are you challenging that corporatization might result in better quality even at that level?
Yes.
Okay.
Valid point. Very valid point. Very, very valid point.
This question?
Sorry. Okay. There are huge ethical issues here. Huge ethical issues. And when I was in health insurance for good 5 years, and I observed this very closely. And when I mentioned the names of those two big hospitals, it actually brought forth, I was totally unaware of it, of what is so badly wrong with the corporate healthcare system here. And I would think twice before advocating that. Consolidation is okay, but corporatization is, it should be a business, I can understand. But if it becomes corporatization in terms of making business out of it, then there is a problem.
Can I also
Wait,
respond
please,
to
wait.
that in the specific context of,
please.
if I could, so answer that in the specific context of PPPs. I think the way I understood Mandar's comment was to say, because there is lack of consolidation, partnering becomes very hard. So if you have, so back to the TB example, if you have thousands of primary care providers, how do you actually make this happen in terms of rolling out the...
Absolutely wrong.
Yeah, okay.
Absolutely wrong. My experience tells me there were 12,000 hospitals empaneled with RSPY, all fragmented, all coming together on a discipline that was created by RSPY. The procedures were defined by the RSPY, the costs were defined by the RSPY, and those fragmented hospitals accepted those procedures and costs. It's a classic example of, I take his point of consolidation, but consolidation is not in the context of corporatization. There's a difference between the two.
Thank you for that comment, because I think that's tremendously important to understand the power of insurance to structure a market, to create expectations for service provision. And the central part of that is it not being just a machine of payment, but the people running it understand its impact on care in the industry. And I think that's what Anil was referring to. And I think that's tremendously important for people to understand in India today, and I don't think is understood in a widespread basis. It's another way to organize the sector that complements the consolidation that might occur on the delivery side. I think we have time maybe for one more question.
Sir, I'm Simran from Press Trust of India, and this question is for Mr. Swaroop. Mr. Swaroop, we have been talking about public-private partnership, and Coal India on several fronts has failed to meet its production target. How are you looking at PPP model when it comes to the coal sector?
Wait a minute, do you want...
Share a secret today. I spent half an hour with her yesterday. She didn't ask me this question. Now she's asking, but nonetheless, I should answer that question. I am a great believer in public-private partnership. I have lived with it and I've seen the benefit thereof. And you can rest assured, Simran, it shall be the way forward for Coal India as well. Is that sufficient or should I elaborate? Then you can come over again for another half an hour, I'll explain that to you. We are talking of healthcare here. Yeah.
All right, wait, hold on one second. I just got a note telling me we have till 1:30, so I thought we were over. Shall we continue? Yes, no? How many yes? How many no? You don't dare show yourselves, huh?
Yeah.
Okay, so we'll go ahead here.
One, can I, Mark?
Yes, please.
I'm Mamta from ISP. My question is to Mr. Anil Swaroop and Milan. See, there are a lot of conversations around PPP in healthcare in past 7-8 years, and I was very much part of Gujarat PPP model. But then the question is, if you take PPP in infrastructure or other areas, when you plan a partnership, there is a clarity on equity, quality, and costs. It could be roads, airports, railways, or anyways. But when we were working on, creating new PPPs in healthcare, it could be on diagnostics or in primary or tertiary, the clarity was missing. Whose role is this to bring the clarity? Is it government, academia, or the industry? Because we are here discussing and debating on no corporatization and where we should segmentize the PPP. So should we look at bringing a clarity in equity first, and then quality and costs?
See, I keep going back to RSPY because that's where I learned most of my lessons. Clarity cannot be a domain of either government or private or academia. It has to be a joint effort. And the reason why RSPY was so clear, everything was precise and clear, because we consulted the stakeholders, all the stakeholders before we took a call. The problem is sometimes I assume that I have all the wisdom in the world and I don't even talk to anybody and do it. But I learned it this way, that I learn a lot by asking you to ask questions. And that's what we did. And that's how it has to happen in PPP. I disagree with as if there are models available somewhere and we'll never come to that model. It's a process of learning. We evolve as we go along. And that evolution also has to come through a partnership. How can I decide sitting in government? When I was talked about those procedure costs in RSBY, you think we did it? I still don't know what those procedures are. I mean, it got the guys sitting there from every possible segment, sat down. I was sitting there more learning. And I could give a different perspective to a discussion. That's how it has to evolve. In the past year and a half before I took over as Secretary Coal, I was looking after these other projects, fast-tracking those projects. That's when I learned what happened in the road sector. The moment you stop the dialogue, we are going down the drain. That dialogue should not stop. It is not that as if we've arrived at a PPP model, and I can't have a prescription for a PPP model. There would be a prescription at a point in time, and it will continue to evolve over a period. That's how I look at it.
You really can't add more value to that answer. But I think the point that he made, you could actually evolve multiple successful models. And I think they will evolve.
Let me, just one sec. We're in the Institute embarked on projects of facilitating capacity building on the government side and bridging the public and private sector. So I'd ask for a little elaboration from our panel as selfish guidance to us as we embark on that, what I hope is not a fool's errand in doing that. How do we improve the communication between public and private sector? How do we deal with some of the distrust across those two worlds that has been referred to and maybe spoken of in the last half an hour in the question period? What do we need to do?
Want me to answer? One of the principal problems in distrust is lack of communication, whether it's between Saas or Bahu or whoever. So you have to set up those communication institutions where you continue to interact. And again, as I keep going back to RSBY, speak with others, get them together, get to discuss. Now, what an institution like ISB could do is to set up those smaller groups with very focused objective. I'll give you an example from what I'm doing right now, how I have already started this public-private partnership and moving ahead. We are looking at, I'm a bit of a digression, but certainly will impact the country. Presently, Coal India mines about 460 million ton. Now we are looking at 1 billion million ton by 2019. Now, do you think Coal India on its own will do it? So what do? We get hold of people from academia, we get hold of industry, we formed into a small group, and who's piloting it? FICCI. I go there, sit with them, we discuss. So everyone is on board, and all of us are working towards this objective of 1 billion metric ton. Now, if I were an ISB, or if ISB were here, I would request them, okay, now you start pivoting this, because the problem in the government is that I am so squeezed with meetings and files that I don't have to think, I have time to think. So someone has to do that thinking process with me. So if that happens there, as it happened in RSBY, we moved ahead. And I can guarantee even in the coal sector, through public-private partnership, we will move. And public-private partnership does not necessarily mean that you put in so much money, I put in so much money. No, it's a public-private partnership of ideas, of moving ahead. Because if you have acceptance of ideas across the board with all the stakeholders, no one can stop you from moving. Even in a difficult sector like health insurance, we could move ahead because all the stakeholders were on board. And to bring them on board, it is important for institutes like ISB or other such institutes to come and bring them together.
Fantastic. Anyone else want to take a bit of a shot? I've already told Anil that whenever he retires, and I realize he's decades away, I am dying to get him on my advisory council because his perception is really acute and clear. Any other?
Yep. I just
Wait,
wanted
wait. Who's? Oh, okay. My boss. I better not cut him off. I hope it's a good question and not a comment.
Now you're putting me on the spot. I was nervous before I started asking this question. Now you made it more difficult. At the risk of maybe oversimplifying or over-stylizing, I just wanted to draw attention to perhaps an obvious point, that one challenge which is peculiar, which is a differentiator for the health sector, as opposed to most other sectors when we think about public-private partnership, is the asymmetry of information between the doctor and the patient. Absolutely. Right? So whether we talk about corporatization and its challenges, whether we talk about the joys of communication, they all get interrupted, disrupted, and filtered by this peculiar aspect, that the doctor is God. And the delivery of the service is based on judgment of the doctor. In the road sector, in the coal sector, the delivery is based on the quantity of coal, on the quality of coal. Whereas here, the doctor has to decide whether you need an MRI or you don't need an MRI. And, you know, how do you begin to regulate that? How do you begin to communicate with that being the provider? That is a challenge which, and you know, it's not a coincidence that the doctor's service to mankind was predicated on RX, the oath, right? Now, how do you mimic the oath in a public-private partnership?
You know, very, very pertinent question, but let me go a step before that. You know, we are assuming that the patient has a choice, that even if he gets that information, he has a choice to go to somebody else. Unfortunately, when we started RSBY, I discovered they don't have a choice. They have to go to the same, sorry for using this phrase, bloody doctor. What RSBY did was to give him a choice. I think that was the USP of that scheme. He didn't have the money to choose one doctor from the other. So before I start answering a question, I have to give him that choice. You have to empower them, enable him to choose a doctor of his choice. Or hospital of his choice. Let's start with that. Your questions are very difficult to answer. Even rich people, even people who can afford to pay, have to go. You are stuck in a hospital and say, this needs to be done. He will ask you to sign a paper. Do you have a choice? You don't have a choice there, though you may have money in your pocket. So there are very, very difficult questions. As I said, those 300 questions that I wrote, I have it somewhere. They were not as intricate as these ones, but even those I don't have all the answers. But you know, I'm a great believer in moving ahead with the answers that I have and I can discover. I mean, these answers I'll discover over a period of time because they are much more important questions that impact the poor man immediately. We have to do that, and for that I would request, I think since we started this discussion here, don't leave it with this conference. Let a small group mull over these issues and work out a roadmap on what really needs to be done. I am no more associated with healthcare, but I'd love to be a part of that discussion if you have that.
We will.
Hi, I'm Harkesh Devas. I'm Country Director for Clinton Foundation. Mr. Swaroop, Clinton Foundation. Despite the remarkable success of RSBY, if you were allowed to change 3 things, what would these be? You alluded to challenges and massive problems. What are these 3 things?
RSBY?
In RSBY. 1, and 2, just building on that point of asymmetry of information, were you able to sort of bring in some standards through RSBY that address that in particular, or was that the most difficult thing to do?
You know, let me answer this second question first. We started with building those protocols, and we could discipline a few things. For the first time in this country, we were incentivizing hospitals to improve the quality of healthcare because we had the power to do it, because we had so much money to back. We could discipline the hospital, but there was still a long way to go. Now, let me come to what, if I were to continue in RSBA, what I would look at. Number 1, it was a cat and mouse game between hospitals and the insurance companies and the patient. Because every time we came up with a mechanism, the hospitals found a way to dupe and get more money. So that's a major ethical issue in terms of the way hospitals were. I mean, even at the cost of sounding nasty, we found a case where a hospital had claimed for 40 patients, none of them had visited the hospital. So you have such extreme cases and not so extreme cases. So that was, preventing frauds and fraudulent practices is going to be the major challenge. Second is the technology part. Though, of course, RSBY rides on technology. There's a lot of technology upgradation was required because we were gradually moving up the scale. The scheme was certainly paperless, but there were instances where we were unable to track, because in RSBY, everything could be tracked. But we are unable to track a few events in RSBY, so technological upgradation would certainly be. And the third and foremost, if this scheme is working for healthcare, for some people, it should be universalized. That platform should be used. And a paper that I wrote with the data from IIM Ahmedabad and got published in Economic Times, I said, if that RSBY smart card is used for public distribution system, the country will save 20,000 crores per annum. So if it could be, that smart card platform could be used for other services.
Sir.
I'm Sushil Ramola from Basics. I would like to take us to the topic, which is universalization of healthcare. And we've been discussing and trying to explore the good way of doing how we can do better through PPPs. But I would like to point out how we can do the right things, and in that context, Ajit made a point in the morning that prevention is 1/10 the cost, so affordability goes up. And in that context, we are forgetting that there are many preventive healthcare practices where India can really be proud of, such as yoga, and similarly the healthcare practices in Ayurveda, which can make it really affordable, and the universalization can happen across the country. So any views from the panelists on what we could do, how we could create public-private partnerships in that area?
Interesting. So it strikes a personal chord with me when we say prevention is better than cure, because when I teach MBA students, everyone wants to know about tertiary care hospitals. And I say, maybe the action is in primary care. Having said that, the point of information asymmetry becomes even more acute when you talk about preventive care. At the end of the day, it is probably more visible, and you can check whether a heart operation was done or not, whether preventive care services were provided and what was the impact of that is very hard to measure, which creates natural inefficiencies in contracting or incentives. Because what you're really trying to compare is some counterfactual. Say, if these preventive services were not provided, what would have been the number of new infections, or what would have been the number of deaths, or whatever. So it creates, it's important, but at the same time it is challenging because of this unobservability of the counterfactual. That's my take on it.
Yeah, if I may add, I'd actually like to look at it from the perspective of what is the continuum of healthcare. And I think it starts from awareness. With awareness can come prevention. Then you get into early stage diagnostics, and then move along the chain. As an example, it is quite stunning, but if you actually look at cancer, awareness of cancer is the single biggest issue today. And once that awareness is actually built up for people to go in for preventive, well, there isn't any known preventive technique, but I think early diagnostics, early detection is very, very important there. In cancer, I mean, if you took 100 rupees as the care of cancer, probably 80% of the cost is in the period where there is nothing that can be done. And it's actually, keeping the patient alive, palliative, and so on and so forth. Whereas if 2% of the amount was spent on early detection, then you probably would not have had to go and spend the balance 98 at all. And I think, therefore, absolutely agree with you, but I'd say start from awareness. And awareness leading to prevention, leading to early diagnosis, and then leading to actually a patient coming into the care system.
I think that's a very important connection, because the awareness, the prevention, early diagnosis is a huge, huge problem in India that stands really beside prevention as sort of the front end that is not being used, that would make a huge difference in outcomes. Sorry, go ahead.
No, I was just going to make exactly the same point, couldn't agree more, which is that, oncology is one area, but even if you take something like child nutrition, statistics will say that even in relatively socioeconomically well-off families in urban India as well, child malnutrition is an issue, and it's not even micronutrient malnutrition that you can solve with fortifying something. It's actual calorific malnutrition, and a lot of this is exactly as Milan said about awareness and behavior change. One place where, bringing it back to this topic, I mean, it is generally felt that the government with its primary health center network and its primary care is the custodian of building this awareness and behavior change in the community. But I actually think that even this is an area where public-private partnership can work, because actually this is where the ideal partnership is possible, because the public sector is actually efficient and effective in changing behaviors, and it does so in when it comes to selling products, when it comes to selling services across the board in rural India, in villages where many of these issues exist. And I think they're a very different kind of public-private partnership, which is not necessarily with healthcare stakeholders, but seeing how, across the board, whether it is retail, and now I mean literally the pawn shop or the retail shop in the village, not even the, I'm not even talking about retail chains, or, partnerships with FMCG companies in driving some of these, awareness and behavior change initiatives can be made to work. And from what we have seen, there does seem to be a reason for both sides to want to work together, because a lot of FMCG companies, for example, do have products that directly talk to prevention and sanitation and so on.
My prediction is primary care is the next front for focus and development in India. Okay, I'm afraid we're out of time. I'd like to thank all our panelists. I think we have some mementos. Do we? Okay.
Thank you.
I'd like to thank all our panelists. I think it's been a fantastic discussion. I think if Anil Swarup had his true freedom, he'd be back with us tomorrow. And thank you all very much for taking part. Take care.